I was early in multifocals. I look back to residency with the original array lens, which was a refractive style lens that did give some depth of focus, but it had a really high complaint and side effect profile. And over the years, what we've seen is that the depth of focus has gotten better. Simultaneously, we've seen less side effect profile. So that's sort of the game. We're always trying to deliver more vision with less side effects.
Yeah, I agree. Like, I'm very scarred and traumatized from the early days of multifocal IOLs. They weren't even, I don't know why we called them multifocal. They were really bifocal.
Yeah.
And they were refractive style lenses, very early technology. It paved the way for sure, but there were some really, really big problems, some really unhappy patients, and it was a struggle. So I abandoned the technology for a long time, and I went in the direction of accommodating IOLs with the crystal lens and did a lot of monovision. And it really wasn't until the last, I'd say probably the last 10 years that I got re-engaged with multifocal diffractive optics, refractive optics, combination optics, extended depth of field optics. We've just seen a tremendous advancement recently. Patients are much happier, much lower side effect profile. And now it's become like mainstream in my practice, using every day.
For a patient to be a candidate for a trifocal IOL, you want to make sure the anatomy is pristine. So in general, if there's corneal problems or surface problems or retina conditions, let's say macular degeneration or epiretinal membrane, things like that, that have any kind of pathology that might decrease the best corrected visual acuity, I think are going to be, less ideal candidates. You want to have a patient that has the best anatomy, to have the best corrected vision potential. And in those cases, if the eye is normal and you don't have that pathology that's limiting corrected visual acuity, I think in general, you're going to have a good candidate based on anatomy. The other side of that is you want to make sure the patient has proper expectations. So number one, you want to make sure that the anatomy is proper, but number two, you want to make sure the patient has that proper expectation and what that trifocal can and can't do.
Yeah, it's become standard of care to get preoperative testing that we never used to get on cataract patients. But now we get corneal topography or tomography on all patients, and we get a retinal OCT on all patients. If we don't pick up on subtle disease processes that are very difficult to see with the naked eye or at the slit lamp and the microscope, we're going to put the lens in the wrong patient. So it's become critical to identify these really subtle conditions like epiretinal membranes or abnormal corneal topographies that would rule someone out from being a candidate for multifocal IOL. So that is a really important part of this. And then, like Bill was saying, there's a lot of people that just by talking to them and interviewing them and asking what their goals are, you can tell that they're probably going to be dissatisfied with the quality of vision of a multifocal, and it's not what they're looking for. Or maybe they use monovision and contacts, and that's what their brain was used to. So maybe stick with that. So you've got to talk to the patients about what they've done in the past with their vision and how they use their eyes, what they're looking for in the future, rule out any pathology. And it's kind of like acting like a detective and putting all these pieces together to form a case.
That's right.
For a toric IOL, it's similar to a multifocal IOL in terms of our pre-op. It's a good history on their eyes and if they've had any surgeries, previous LASIK, RK, or anything like that, or any surgeries, how they use their glasses and contacts historically, how much they're wearing their glasses, and then it's that corneal topography that identifies the astigmatism, which is very important, as well as their refraction, and checking their retina health as well as the density of their cataract. And most patients with high astigmatism, they know they've heard that word before, and that's pretty easy talking to them about correcting their astigmatism. Other patients, they've never heard that word before, because if they only have a low amount of astigmatism, they might not have heard about it, but everybody has a little bit. And we use the laser a lot to correct low amounts, or sometimes we'll use a toric. So sometimes there is an educational process to explain to the patient about what astigmatism is. Most importantly, to help them understand that if we don't correct astigmatism, they'll probably need glasses for distance vision. So it becomes an important part of the conversation in the cataract consult.
In addition to that, preoperative information or that goes along with the preoperative diagnostics, there are some new technology that allow for digital guidance with that preoperative information to help assure you're placing that toric lens on the proper axis. When you're choosing that toric lens, you want to make sure not only is it the correct power, which a lot of the preoperative diagnostics are much better at predicting, but also you want to make sure you place that toric lens in the correct position inside the eye. And thankfully, there is current technology that really aids in that surgeon guidance for positioning that lens to assure you're getting the best effect.
I think everybody has their own technique. There's multiple platforms for toric lenses. They all behave slightly differently when you put them inside the eye. Some are a little more slippery and can move a little more easy. Some are a little bit more rigid and tend to take a little more energy to get them to rotate. But what I like to do is I like to deliver the toric lens into a nice soft open capsule with a nice bed of viscoelastic. And I like to get the lens exactly where I want it to be. And I happen to use a technology that's made by the LensR company called the Ally technology with IntelliAxis, where we make little marks on the capsulotomy. So I've got a digital created mark, not digital, but it's a mark created by the laser of where to put the lens. So I just put the lens there. And when I go in then with my INA, I just touch it right down to the IOL in the back of the bag and hold the lens still and start evacuating the viscoelastic and maybe just rock the tip a little bit in the lens. And then I gently come out and hydrate the wounds, and it just usually stays right where I left it.
Those are great pearls. And I think, making sure the incision is properly sealed, surgical technique, if that anterior chamber were to collapse or anything like that, you could have that lens, moving. So you want to make sure the eye is stable at the end of the case. Also, lens platforms, there are different lenses, the way the material that they're made out of, or the haptic configuration can allow for either a more stable or less stable configuration. Thankfully, some of the newest lens designs, in particular the BVI platforms, allow for a very stable haptic configuration that can help assure where you've placed that lens is where it's going to be, day one, week one, or month one. So it allows for both short-term and long-term stability.
Cataract surgery, no matter how hard we try, there are always things that come up unexpected. We might break a capsule and put a lens in, and we don't stabilize that lens inside the bag or in the sulcus, and it decenters or tilts. There are patients that are unhappy with the technology that we recommended for them. A lot of times we're off on our visual targets where we thought we picked the right IOL power, but sometimes the math doesn't make sense, and the effective lens position isn't how the eye actually healed, and we're off target. So we are constantly faced with the possibility of having to go back in an eye and clean things up, either switch out a lens or recenter a lens or put in sutures to fixate a lens. And that's become part of the game. When I first started doing this, the idea of going back in the eye was just a nightmare. It was like the last thing you would ever want to do. Now it's become routine to where when you work with these advanced technologies, you have to understand that there's a chance you're going to need to go back in that eye and do some more work.
Anytime you place a premium IOL, the risk of needing a secondary operation goes up. Like Rob said, for the performance of those lenses to work well, it has to be the perfect diopter, the perfect position, perfect anatomy. And I think all surgeons needs is prepared to choose, to be able to make adjustments later. Yeah, I think Rob brings up some great points that, in the modern era, when doing premium surgery, you need to be prepared that outcome may need to be adjusted in the future. For example, maybe the patient doesn't adapt to the optics, or maybe you have to make an adjustment to the optical power or treat astigmatism later. So you should be prepared either to do an IOL adjustment or maybe do corneal refractive surgery at a later date. And so, to get the best performance, you want to make sure everything is perfect for that patient, and that may require a secondary surgery.